Hello guys. Welcome to the third video of our endocrinology series. In this video, we'll cover the thyroid and the parathyroid glands, which together control two critical things, metabolism and calcium balance. The thyroid controls how fast or slow the body runs, and the parathyroid controls how much calcium stays in the blood. So for USMLE, most questions in this system are mostly asked about lab patterns, feedback loops, and recognizing classic diseases like Graves, Hashimoto, hyperthyroidism. If you understand this logic, you will be able to memorize all the tables and we can easily solve all the questions related to thyroid and parathyroid. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for all the students. If you find it useful and wish to support its development, you can contribute using the link that is present on the screen and also pinned in the description. You can pay with any of these payment methods. Thank you. So in this video, we'll cover, thyroid and parathyroid glands, how they control. And so metabolism and calcium balance are the two critical things in our body. So these glands control these metabolism and calcium balance in our body. And the USMLE focuses on lab pattern cognition, feedback loops, and disease uh, algorithms of most important disease like Graves, Hashimoto, hyperparathyroidism, hypothyroidism. So all these are the key areas that are tested. If you understand this logic, you won't need to memorize random tables. So you just have to understand the lab pattern cognition, the feedback loop, and high yield disease algorithms and pattern cognition. The thyroid gland mainly produces T3 and T4, which regulate metabolic rate and affect almost every organ. Whereas a parathyroid gland produces parathyroid hormone, which regulates calcium and phosphate in our body. A simple rule to remember is that thyroid uh, maintains the metabolism, whereas parathyroid maintains the calcium levels in our body. So, in this video, we'll be learning and we'll be going step by step. So, like embryology, anatomy, physiology, and then we'll study about diseases, the drugs, and finally, we'll study about some high yield laboratory patterns. So, the goal in this video is to build logic first and then start applying it to questions. The thyroid develops from the endoderm at the foramen cecum of the tongue and migrates down into the neck. During its ascent, it remains connected to the, thyroglossal duct. Any problem in this descent can leave remnants behind, and this can present with a midline neck mass. Thyroglossal duct cyst. A thyroglossal duct cyst, it presents as a midline neck swelling that moves with swallowing or tongue protrusion. So this is a classic USMLE clue. So whenever you see a question mentioning a midline neck swelling that moves with swallowing or tongue protrusion, we need to remember and we need to first remember that it might be potentially a thyroglossal duct cyst and it results from persistent thyroglossal duct. So if you see a midline neck mass that moves, think of a thyroglossal duct cyst. The clinical importance includes that it can get infected and it can cause dysphagia and cosmetic issues. Now we'll study about the embryology of the parathyroid glands. The parathyroid comes from the pharyngeal pouches. The third pouch gives rise to the inferior parathyroids in the thymus, whereas the fourth pouch gives rise to the superior parathyroids. The confusing part is that the inferior ones descend more, so they end up lower. So these inferior parathyroids are derived from the third pharyngeal arch, whereas the superior parathyroids are derived from the fourth pharyngeal arch. But the inferior parathyroids that are derived from the third pharyngeal pouch, they descend more. They descend more, so they end up being lower. The superior parathyroids descend less and end up being higher. Now let's study about the DiGeorge syndrome. So in DiGeorge syndrome, there are there's abnormal development of third and fourth pouches. This leads to hypocalcemia from absent or hypoplastic parathyroids, thymic aplasia, which leads to T cell deficiency, and the other key feature is cardiac defects, which can present as conotruncal anomalies. So infections plus hypocalcemia plus heart defects. You should think of DiGeorge syndrome. So the key features includes hypocalcemia due to absent parathyroids, thymic aplasia presenting as T cell deficiency and suppression, cardiac defects might be a presenting feature. So whenever you see a child with infections, hypocalcemia, and a heart defect, you need to think of DiGeorge syndrome. Anatomy of the thyroid gland. The thyroid sits in front of the trachea and has two lobes connected by a fibrous tissue called as the isthmus. So it's very vascular, and it lies close to the recurrent laryngeal nerve and the parathyroids, which explains its surgical complications. So whenever we operate a thyroid gland, we need to be cautious about the recurrent laryngeal nerve. So any thyroid surgery might present with hoarseness. So it is a very important surgical complication of thyroid surgeries. So, thyroid surgery can injure the recurrent laryngeal nerve and lead to hoarseness of voice. So, the recurrent laryngeal nerve supplies most of the intrinsic laryngeal muscles. Injury of this recurrent laryngeal nerve causes hoarseness. So, hoarseness after thyroid surgery strongly suggests nerve injury. Usually, there are four parathyroid glands on the posterior surface of the thyroid. Because of embryological migration, their position can vary and they can be accidentally removed during thyroid surgery, which can lead to hypocalcemia as a presenting feature. So, post thyroid surgery presenting with tingling or tetany, think of hypocalcemia from parathyroid injury as a complication of a thyroid surgery. So now let's revise the embryology anatomy of and anatomy of thyroid and parathyroid. We have already studied that inferior parathyroids and thymus arises from the third pharyngeal pouch, whereas the superior parathyroids arise from the fourth pharyngeal pouch. So yeah, Discharge syndrome is failure in the development of third and fourth pharyngeal pouches, which presents with three features we have already discussed. Heart defects. What are those? Heart defects, uh, T cell suppression, and hypocalcemia. Whereas coming to the thyroid gland anatomy, uh, the thyroid gland, so this is the thyroid gland that is present in front of the midline of the neck, and both the lobes are connected by a fibrous tissue called as the isthmus that we have seen here. This is so it is closely related to the recurrent laryngeal nerve. So injury of the recurrent laryngeal nerve is the most important complication during thyroid surgeries. Now let's discuss about thyroid hormone synthesis. So the thyroid produces T3 and T4 inside the follicles and stores them in the colloid. So this is unique because most endocrine glands do not store large amounts of hormone. Most endocrine glands, they do not store large amount of hormone. They just release it into the bloodstream. Whereas thyroid glands synthesize T4 and T3 and they store them in thyroid follicles in the form of colloid. So colloid, presence of colloid is a typical feature of thyroid histopathology. So whenever they give histopathological images of a gland with a hyalinous colloid-like structure, we need to think about a thyroid gland. And these T4 and T3 are usually stored as colloid in those thyroid follicles. They're stored in colloid and bound to thyroglobulin. So they're stored in a bound form. T4 and T3 synthesis requires iodine. T3 and T4 synthesis requires large amounts of iodine. So thyroid is the only endocrine gland that stores large amounts of hormone. So there are different steps in the synthesis of thyroid hormones. The first step is iodide trapping. So iodide enters the thyroid follicular cell through a sodium iodide symporter. So this is the first step. So this sodium iodide symporter is present on the basolateral membrane. So this iodide trapping is the first step in thyroid hormone synthesis, and this is done with the help of sodium iodide symporter that is present on the basolateral membrane. It enters the thyroid follicular cell. then it is stimulated by TSH. So this sodium iodide symporter is stimulated by TSH, and it uses a secondary active transport to trap iodide into the thyroid follicular cell. So clinical relevance is that it is this can be inhibited. This step can be blocked by some substances like perchlorate and thiocyanate. So iodide trapping is the first step in thyroid hormone synthesis. This is a key point from this slide. The second step in thyroid hormone synthesis is oxidation and organification. The first step is iodide trapping, and the second step is oxidation and organification. Thyroid peroxidase oxidizes iodide and attaches it to tyrosine residues on the thyroglobulin and forms MIT and DIT, monoiodotyrosine and diiodotyrosine. This enzyme is thyroid peroxidase is definitely highly tested on USMLE. So iodide is oxidized to iodine. Iodide I minus is the ionic form. Anionic form. This is oxidized to iodine I2 by thyroid peroxidase TPO. Iodine is attached to tyrosine residues on the thyroglobulin. This step is called as organification. The first substep is oxidation, and the second substep is organification. And this leads to the formation of monoiodotyrosine and diiodotyrosine. So both this oxidation and organification requires an enzyme called thyroid peroxidase. The third step in thyroid hormone synthesis is coupling. So two DIT molecules form T4, one MIT plus one DIT forms T3. More T4 is produced, but T3 is more active. So when coming to thyroid hormones, you have to remember that the major hormone that is produced by the thyroid gland is T4, whereas the more active form is T3. So most of the thyroid hormones are synthesized in the form of T4, which is an inactive form, whereas T3 is an active form, is synthesized comparatively less. This is stored in the colloid and is bound to thyroglobulin until release. The next step is release into blood. Thyroglobulin is endocytosed. It is broken down, and T3 or T4 and T3 and T4 are released into blood. Most hormone is bound to binding proteins named as thyroxine binding globulin (TBG), and only the free hormone in the form of T3 is the biologically active component. So changes in binding proteins change total, not free hormone levels. So whenever there are changes in binding proteins like TBG, it changes the total hormone levels, not free hormone levels. So now let's learn about regulation by TSH, regulation by thyroid stimulating hormone. The hypothalamus releases TRH and the pituitary releases TSH, and which leads to the release of T3 and T4 from the thyroid. TSH increases all the steps of synthesis and gland growth. So the effects of TSH includes increased iodide trapping, increased TPO activity, increased hormone synthesis and release, and increased thyroid gland growth. TSH is the main regulator of thyroid hormone production. So this TSH is the main regulator of thyroid hormone production. TRH from hypothalamus leads to release of TSH from pituitary, which leads to release of T3 and T4 from the thyroid gland. So effects of TSH includes it increases iodide trapping at the follicular cell level. It increases TPO activity. Increased TPO activity leads to increased oxidation and organification, increased hormone synthesis and release, and which also increases the thyroid gland growth. So TSH also plays a role in increasing the mass of the thyroid gland. So peripheral conversion. So most hormone secreted is T4, but the active component is T3, as I already studied. Peripheral tissues convert this T4 to T3 using enzymes called as deiodinases. So T4 to T3 conversion by 5-deiodinase occurs in the peripheral tissues. This T3 is more potent than T4. Some T4 is converted into reverse T3, which is an inactive component. So some T4 is converted into reverse T3, which is an inactive component. Many tissues control their own thyroid effect by local conversion of T4 to T3 using 5-deiodinase. So factors affecting conversion, drugs like propylthiouracil, propranolol, and amiodarone, what they do is that, and severe illnesses, they reduce T4 to T3 conversion. So this explains. So This explains the euthyroid 6 syndrome. So 5-D iodinase activity is decreased using drugs like propyl thiouracil, amiodarone, beta blockers like propranolol, glucocorticoids, and in cases of severe illness, in all these cases, 5-D iodinase activity reduces, which leads to fall in the levels of T3, which eventually leads to a condition called as euthyroid 6 syndrome. So low T3 with normal or low T4 in a sick patient, we need to think about decreased conversion. Now let's discuss about the mechanism of action of thyroid hormones. So thyroid hormones act via nuclear receptors. They are similar to steroid hormones, as we already discussed. These thyroid hormones are similar to steroid hormones in how they act. So they act through the nuclear receptors and they change gene transcription, similar to steroid hormones. This is why their effects are widespread. So it enters the cells, binds nuclear receptors, and alters gene transcription. It increases basal metabolic rate, increases heat production, increases heart rate and cardiac output, and increases sensitivity to catecholamines. Thyroid hormones act like steroids at the receptor level. So steroids, vitamin D, and T3 and T4, all these act through the nuclear receptors and are more similar to steroid hormones. So now let's discuss about the clinical effects of these hormones. Too much hormone causes, weight loss, heat intolerance, and tachycardia. Excess thyroid hormone, hyperthyroidism causes weight loss, heat intolerance, tachycardia, tremor, and anxiety. Whereas a decreased thyroid hormone, deficient thyroid hormone, or hypothyroidism causes weight gain, cold intolerance, bradycardia, fatigue, and constipation. So symptoms reflect metabolic speed, too fast or too slow. So weight loss, heat intolerance, tachycardia, tremor, and anxiety are features of hypothyroidism. Whereas weight gain, the opposite, cold intolerance, the opposite, bradycardia, the opposite, fatigue and constipation, all these are features of hypothyroidism. Let's discuss about hyperthyroidism. And the common causes of hyperthyroidism includes Graves' disease, toxic nodules, and thyroiditis. The key in identifying these conditions is that we have to use symptoms, labs, and radioactive iodine uptake together to come to narrow down to one specific diagnosis. So hyperthyroidism means excess thyroid hormone effect on the tissues. The common causes includes Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis, and excess thyroid hormone intake. The USMLE focuses uh, in questions, and we have to answer those questions by combining clinical features, labs, and how the radioiodine uptake occurs, and we can narrow down to one specific diagnosis among these. Coming to Graves' disease, it is an autoimmune condition with antibodies stimulating the TSH receptor. This causes diffuse goiter. This causes, diffuse goiter, ophthalmopathy, and pretibial myxedema. IgG antibodies stimulate the TSH receptor. This causes increased T3 and T4 production. This leads to diffuse thyroid enlargement. The clinical features includes hyperthyroid symptoms like diffuse goiter, ophthalmopathy, exophthalmos, and pretibial myxedema. So Graves' disease, you can identify using a question mentioning TSH receptor and stimulating antibodies. Now coming to thyroiditis. In thyroiditis, the preformed hormone leaks out, so the uptake is low. So the radioiodine uptake in this case is low. Preformed hormone leaks out. There's often a transient hyperthyroid phase, which is followed by a hypothyroid phase, and then recovery occurs. So thyroiditis causes release of preformed hormone, not increase its synthesis. The types of thyroiditis include subacute, which is painful and post-viral, which is also called as decuvariant thyroiditis, whereas painless and postpartum thyroiditis, it is due to an autoimmune condition. The features of thyroiditis includes transient hyperthyroid phase, then it is followed by a hypothyroid phase, then it is followed by recovery. So thyroiditis leads to low radioactive iodine uptake because of leakage of hormone. Now, when we start to discuss about toxic adenoma and toxic multinodular goiter, the toxic nodules, uh, these conditions produce hormone autonomously. These conditions produce hormones autonomously. The uptake is focal or patchy, and there are no eye signs in conditions like Graves' disease. These cause hyperthyroidism due to autonomous hormone production. The features includes one hot nodule, toxic adenoma, multiple hot nodules, toxic multinodular goiter. TSH is suppressed in these conditions, and there are no eye signs, unlike Graves. So, focal or patchy uptake plus hyperthyroidism, we have to think about toxic nodules. Radioactive iodine uptake patterns. High uptake means increased synthesis, like in Graves and toxic nodules. Low uptake means leakage or external hormone, like in thyroiditis. Okay, high uptake, increased synthesis, low uptake, leakage of hormone. So high uptake is seen in conditions like Graves, toxic adenoma, toxic multinodular goiter. In all these conditions, there is increased synthesis of these hormones. Whereas in thyroiditis, exogenous thyroid hormone and iodine excess, there is hormone leakage or exogenous intake in these conditions, which leads to low uptake of radioactive iodine. Now coming to uh, uh, let's discuss, let's revise these features of hyperthyroid conditions once again. So what happens is that in Graves' disease, autoantibodies are formed against the TSH receptor, and because of overstimulation of these TSH receptor, there is increased T3 and T4, which leads to hyperthyroid symptoms, ophthalmopathy, and pretibial mixed edema. Whereas thyroiditis, there is leakage of preformed hormone. There are two types, subacute and painless or postpartum. So there is a transient hyperthyroid phase, which is followed by a hypothyroid phase. Then there is a recovery. In this thyroiditis, a radioactive iodine uptake is low. Toxic nodules, there is autonomic hormone production. There is one hot nodule, toxic adenoma, and there are multiple hot nodules in case of toxic multinodular goiter. There is suppressed TSH in these conditions, and there are no eye signs in case of toxic nodules. And it can be identified using focal or patchy infiltrate on radioactive iodine uptake. So now coming to the treatment of thyroid conditions, specifically hyperthyroidism, the main options we use includes anti-thyroid drugs, radioactive iodine, and surgery. Beta blockers are used for symptom control in cases of hyperthyroid conditions to control palpitations, tremor, and anxiety. So the choice depends on the cause, the age, the pregnancy status, and the severity. So taking all these into consideration, we decide which treatment options should the patient be started upon. Now coming to the first antithyroid drugs, thionamides. So the main drugs like methimazole and propylthiouracil, they inhibit thyroid peroxidase. Propylthiouracil also blocks peripheral conversion of T4 to T3. This peripheral conversion, as we have already discussed, is mediated by an enzyme called as 5-D iodinase, and this propylthiouracil inhibits this 5-D iodinase. So it inhibits peripheral conversion of T4 to T3. So the mechanism of these thionamides, methimazole and propylthiouracil, they inhibit thyroid peroxidase and in turn inhibiting oxidation and organification, TPO inhibition and T4 to T3 conversion inhibition. So both these occur in case of usage of propylthiouracil. The big dangerous side effect of thiamides is agranulocytosis. So fever and sore throat in these patients is an emergency. So whenever there is fever and sore throat in these patients on thiamides, we have to suspect agranulocytosis, and this is a medical emergency. So common side effects includes rash and arthralgia. The serious side effects includes agranulocytosis and hepatotoxicity, which is more common with propylthiouracil. Radioactive iodine and surgery. Radioactive iodine destroys thyroid tissue but is contraindicated in pregnancy. Surgery is used for large goiters or suspected cancers. So it destroys the thyroid tissue used in Graves and toxic nodules. This is contraindicated in pregnancy. It is used for large goiter, suspicion of cancer, and failed medical therapy. The complications includes hypocalcemia, where it can occur due to injury to the parathyroid glands and hoarseness due to injury of the recurrent laryngeal nerve during thyroid surgeries. So beta blockers, when they are used in conditions of hyperthyroidism, like propranolol, it controls the symptoms and also reduces T4 to T3 conversion, but it's not the definitive treatment. This is used for symptom management, symptomatic control. This is not definitive treatment. Now let's study about the treatment overview of hypothyroidism. So hypothyroidism is most commonly caused by a Hashimoto condition in iodine sufficient areas and iodine deficiency worldwide. So hypothyroidism means insufficient thyroid hormone effect on the tissues. The common causes includes Hashimoto thyroiditis, which is more common in iodine sufficient areas, and iodine deficiency, which is the most common cause worldwide. Post-thyroidectomy and radioiodine therapy are other causes. Drugs like amiodarone and lithium also cause hypothyroidism, and congenital absence or defects also present with hypothyroid features. So always combine symptoms and labs to identify the cause. So Hashimoto thyroiditis is an autoimmune condition with anti-TPO antibodies, painless goiter, and increased risk of thyroid lymphoma and increased risk of thyroid lymphoma. So Hashimoto thyroiditis is an autoimmune disease. Autoantibodies against thyroid peroxidase and thyroglobulin. There is gradual destruction of thyroid tissue. There are hypothyroid symptoms, painless goiter, and increased risk of B-cell lymphoma of the thyroid. Anti-TPO antibodies plus hypothyroidism. Iodine deficiency hypothyroidism. So this iodine deficiency, in this iodine deficiency hypothyroidism, low iodine means low T3 and T4, and this leads to feedback loop of high TSH and goiter due to stimulation. So high TSH in turn leads to growth of the thyroid gland. So decreased T3 and T4, which leads to increased TSH in feedback loop. This causes goiter due to TSH stimulation, hypothyroid symptoms, and enlarged thyroid gland, most common cause of hypothyroidism worldwide. In subclinical hypothyroidism, TSH is high, but T3 and T4 are normal. This is early thyroid failure. Normal T3 and T4, elevated TSH, early or mild thyroid failure. It is often asymptomatic or with mild symptoms. It can progress to overt hypothyroidism and may need treatment in selected patients. High TSH plus normal T4, there is subclinical hypothyroidism. In mixed edema, there is severe hypothyroidism which causes hypothermia, bradycardia, and altered mental status. Mixed edema coma is a medical emergency. This is a medical emergency which is triggered by infection, cold exposure, and drugs. So the features includes hypothermia, bradycardia, hypotension, altered mental status, and non-pitting edema. Mixed edema coma is a medical emergency and is triggered by infection, cold exposure, and drugs. So the treatment for mixed edema coma is we have to give IV levothyroxine and also provide supportive care for these conditions like hypothermia, bradycardia, hypotension, altered mental status, and non-pitting edema. So these are the features of mixed edema. Now let's try to revise this once again. So hypothyroidism is characterized by weight gain, cold intolerance, fatigue, bradycardia, and constipation. Whereas the common causes of hypothyroidism includes Hashimoto thyroiditis, post-thyroidectomy or radioiodine therapy, iodine deficiency, and drugs like amiodarone lithium. Thyroid nodules, most nodules are benign, but some need a biopsy. So what need a biopsy is a key thing that we have to remember and we have to identify in order to prevent thyroid cancers. So identify who needs a biopsy and recognize red flags for cancer. Use TSH and radioactive iodine uptake to guide evaluation. Not every nodule is a cancer, but some must be definitely ruled out before uh, excluding cancers. Now let's discuss about the initial evaluation of thyroid nodule. Check TSH first. So if it's low, we do a scan. If normal or high, we do an FNA. If it's normal or high, we do an FNA. So whenever we see a case of a thyroid nodule, first thing is that we have to measure the TSH. If TSH is low, then we have to do radioactive iodine uptake scan. If it is normal or if it is high, we need to do a fine needle aspiration biopsy. So TSH first, then we have to decide whether scan or biopsy. Scan in case of low TSH, whereas biopsy FNA in case of normal or high TSH. Now let's try to differentiate between hot and cold nodules. So hot nodules are rarely malignant, whereas cold nodules are more concerning. Hot nodule, there is high uptake on radioactive iodine scan. It produces hormones and it is rarely malignant, whereas cold nodule, there is low uptake on radioactive iodine uptake scan. It does not produce hormone and there is a higher risk of malignancy with these cold nodules. And these hot nodules are rarely malignant. Cold nodules are more concerning for cancer. So now let's try to discuss about thyroid hormones. So papillary thyroid carcinoma is most common and it also has a best prognosis. So papillary thyroid hormone is characterized by being most common and also it also has the best prognosis. Whereas anaplastic carcinoma has worse prognosis and medullary is associated with Mentu syndrome and calcitonin production. So always we have to know key associations and prognostic factors. So the main types of thyroid cancers includes papillary, follicular, medullary, and anaplastic. Papillary is the most common form of thyroid cancers, whereas these papillary cancers have best prognosis, whereas anaplastic cancers have worse prognosis. Medullary cancers are associated with MEN2 and calcitonin. Always we have to know key associations and prognosis. The high yield features of major thyroid cancers includes papillary has orphan ani nuclei, follicular uh, spreads hematogenously, whereas medullary comes from the parafollicular C cells, and anaplastic is the most aggressive and worst prognostic thyroid cancer. So, papillary, we have to remember these 3 points. There is orphan ani nuclei, which is a indicating factor for which this orphan ani nuclei is a characteristic feature of papillary thyroid cancers. Also, on histopathology, we can find Samoma bodies. So, orphan ani nuclei and Samoma bodies are typical features of papillary thyroid cancer. It is the most common thyroid cancer and it also has the best prognosis and it spreads by lymphatic spread. Whereas follicular thyroid cancers have hematogenous spread and we cannot distinguish follicular thyroid carcinoma from adenoma on fine needle aspiration cytology, so we have to remember this. In medullary thyroid carcinoma, this medullary thyroid carcinomas arise from the parafollicular C cells. It produces calcitonin and is associated with MEN2 and also associated with production of calcitonin. Anaplastic thyroid carcinomas are very aggressive. They have poor prognosis and they are mostly seen in elderly patients. So now trying to discuss about the parathyroid hormone, let's start about the parathyroid hormone. So the parathyroid hormone raises calcium and lowers phosphate. It acts on the bone, kidney, and indirectly it also acts on the gut via vitamin D. So parathyroid hormone is the main regulator of calcium in the body. It increases serum calcium and decreases serum phosphate. The target organs includes bone, kidney, and gut. It targets gut indirectly via vitamin D. So if calcium is low, PTH should go up. PTH actions includes in bone, it increases resorption. In kidney, it increases calcium reabsorption and decreases phosphate reabsorption. So in bone, PTH increases bone resorption via osteoblast-mediated osteoclast activation. It releases calcium and phosphate into blood, whereas kidney increases calcium reabsorption and decreases phosphate reabsorption, phosphaturia. And also it leads to increased activation of vitamin D. PTH rises calcium and lowers phosphate. Vitamin D increases calcium and phosphate absorption from the gut, and parathyroid hormone stimulates the synthesis of this vitamin D. So, vitamin D increases calcium absorption from the gut, parathyroid hormone absorption from the gut. The in skin or diet, whenever there's so this vitamin D, after being after the intake, either through the skin or through diet, it travels through the liver and then at the level of the kidney, by the action of 1-alpha hydroxylase, it is converted into an active form of vitamin D, which is called as calcitriol. So the effect of this parathyroid hormone includes that it stimulates 1-alpha hydroxylase in the kidney. Parathyroid hormone raises calcium directly and indirectly via vitamin D. Calcium regulation. Low calcium increases PTH. High calcium suppresses PTH. We always need to interpret calcium with PTH. Low calcium leads to high PTH and high calcium leads to low PTH. So PTH increases calcium, vitamin D increases calcium, calcitonin decreases calcium. So it has a minor role in adults. Always interpret calcium together with PTH. So the laboratory patterns in case of parathyroid hormone conditions include high PTH gives high calcium and low phosphate, whereas low PTH gives low calcium and low phosphate. High PTH causes high calcium and low phosphate, whereas low PTH causes low calcium and high phosphate. So high PTH, high calcium, low phosphate, low PTH, low calcium, high phosphate. So this table is extremely so this laboratory patterns of high PTH and low PTH is extremely high in case of identifying hyperparathyroidism, hypoparathyroidism, and hypoparathyroidism vitamin D disorders. First, we need to look at calcium, and then we need to look at PTH. There are three different kinds of hyperparathyroidism: primary, secondary, and tertiary. The key is to look at calcium and PTH together. So hyperthyroidism means excess PTH. Primary, there is a problem in the parathyroid gland itself. In secondary, there is a defect in the response to chronic hypoglycemia. And in tertiary, there is autonomous hypocalcemia. In tertiary, there is autonomous parathyroid hormone after long-standing secondary hyperparathyroidism. The core effect is that there is high PTH, which leads to high calcium and low phosphate. So identify the type using labs and clinical context. Always do this. So primary, there is a problem in the parathyroid gland itself. Whereas in secondary, there is a defect in response to chronic hypocalcemia. Whereas in tertiary, there is defect in autonomous parathyroid hormone after long-standing secondary hyperparathyroidism. Primary hyperparathyroidism is most commonly due to adenoma. Laboratory patterns shows high PTH, high calcium, and low phosphate. Always, when we think about hyperparathyroidism, we need to think a phrase called stones, bones, groans, and psychiatric stones, kidney stones, bones, bone pain, groans, abdominal pain, and psychiatric overtones, neuropsychiatric symptoms. So the clinical features of primary hyperthyroidism includes stones, bones, groans, psychiatric overtones. Secondary and tertiary hyperthyroidism. Secondary hyperthyroidism is due to chronic hypocalcemia, usually due to chronic kidney disease, whereas tertiary is autonomous PTH after long-standing secondary hyperparathyroidism. So, secondary hyperparathyroidism, the cause includes chronic hypocalcemia, most commonly chronic kidney disease, high PTH, low or no normal calcium, and high phosphate in CKD. Tertiary hyperparathyroidism, there is long-standing recovery. The glands become autonomous. The laboratory pattern includes high PTH and high calcium. Secondary, there is compensation. Tertiary, there is autonomy. Hypoparathyroidism is most common after thyroid surgery. So the labs show low PTH, low calcium, and high phosphate with tetany and tingling. So post-thyroidectomy, most common autoimmune and T-George syndrome, low calcium plus low PTH, hypoparathyroidism. The clinical features of hypothyroidism includes perioral numbness, tingling, tetany, and seizures in case of severe cases. The treatment of hypoparathyroidism includes firstly treating the cause, and then we can do a surgery for adenoma. Whereas in hypoparathyroidism, the mainstay of treatment is calcium and vitamin D supplementation. To summarize, the thyroid controls metabolism, the parathyroid hormone controls calcium. Graves and Hashimoto's are the most common causes of hyper and hypothyroid states, respectively. Thyroid nodules need TSH-based evaluation, and then we have to decide whether to do a radioactive iodine uptake scan or fine needle aspiration biopsy, depending on the TSH levels in case of thyroid nodules. Parathyroid disorders are solved using calcium and PTH patterns. So, this lecture series on endocrinology consists of 6 videos. So, this is the third video. We'll be completing with fourth, fifth, and sixth videos very soon. So, that will be the end of the endocrinology series. I think and I hope this series is definitely helping you guys. So, I would like to request you to subscribe and please supporting. I'll meet you in the next video with adrenal glands. Yeah, thank you.